Hi, I'm Mike Larson, and I'm an abdominal radiology doctor at the University of California, Davis, and I'm leading a project to do surgery through a needle to fix hiatal hernias. This picture on the left is kind of a diagram of lungs, diaphragm is missing, there's liver, stomach is, the esophagus and stomach is the structure that's highlighted in yellow. The hole in the diaphragm for the esophagus and the aorta to go through is the diaphragm hiatus. So a picture on the right is kind of showing a hiatal hernia is where the stomach tries to herniate upward into the lower aspect of the chest. Hiatal hernias can cause symptoms of chest pain, epigastric discomfort. They can contribute to acid reflux or heartburn. The gold standard for hiatal hernia repair is fundoplication. This picture on the left shows the fundus, or the top part of the stomach, and fundoplication is where the fundus is wrapped around the junction of the esophagus and stomach to, one, make acid less likely to go up, and two, to create more bulk so that the stomach doesn't herniate upwards into the lower aspect of the chest. The current treatment is great, but it does have limitations. The recovery time for healing is generally weeks. There are a handful of complications, like up to 4% will need minor treatment, and there are rare worse complications. There are occasional side effects from fundoplication, like most people can't burp afterwards, meaning they get more bloated easily. And since it's harder for acid to sneak up the esophagus, it's also harder sometimes for food to go down into the stomach, leading to dysphagia or difficulty eating. There are costs and there are hernia recurrences where the hernia or symptoms just come right back. This is a graph from an article published in 2017 showing how after about 5 years, about 1 in 5, well, after maybe 6 years, about 1 in 5 patients that have had their hiatal hernia repaired will have symptoms recur. So it's great, but it's not perfect. Before the fundoplication became the gold standard surgical treatment for hiatal hernia, there was another surgical option. In 1956, a Dutch surgeon named Dr. Boerema started surgically anchoring the stomach to the abdominal wall to treat this herniation. So pexy is the surgical term for anchoring. So these two pictures are of a hiatal hernia at different angles, where you can see a blob of stomach. It's kind of in panel A. The middle black blob is the top of the stomach, and you can see that it's herniated upwards above the diaphragm. And as shown in B, basically the Boerema gastropexy was just where the surgeon would cut a small hole in the abdominal wall, hold the stomach down back below the diaphragm, anchor the stomach to the abdominal wall, and then sew the patient up. This Boerema anterior gastropexy technique worked well for most patients, but not for some surgeons who didn't really do what the Dutch surgeon had originally published, but still erroneously called it the Boerema anterior gastropexy. Anyways, you can kind of see this middle-ish column results, the percentage of excellent results. Surgeons had excellent results. The majority of cases, except for the one instance where the surgeons were doing something different and calling it the Boerema gastropexy, but the results, they weren't as great as the fundoplication later on. So this more simple surgery fell out of practice in the 1980s, 1990s. However, owing to the relative simplicity and straightforward Boerema gastropexy over fundoplication, a group of surgeons trialed it again in 2014. It worked completely in 70% of patients, less well in about 20%, and didn't really change symptoms in about 10% of patients. So this is not as good as a fundoplication, but it worked. A radiology doctor, meaning I have extensive training using different medical imaging tools like CT or fluoroscopy to evaluate anatomy, including having to evaluate hiatal hernias. And then I have added training and experience in using medical imaging tools to guide needles into tricky places. This on the left is an artist's rendition of a radiologist at work placing a feeding tube for when a patient won't be able to eat for a prolonged period of time. Before I poke a big hole into the patient's stomach in order to be able to place this feeding tube into the stomach, I first poke 3 smaller anchors to temporarily hold the stomach to the abdominal wall before I have to poke in a much bigger needle to get this into the stomach. So we routinely place feeding tubes here at UC Davis, and as part of that, we do a temporary gastropexy. I have an approved study at UC Davis to modify the feeding tube placement procedure to try to mimic the surgical Boerema gastropexy. In this, I'll place temporary needle anchors into the stomach, and then instead of inserting a big feeding tube, I'll place some barbed suture to anchor the stomach to the abdominal wall to prevent the stomach from herniating upwards. So you can see kind of a diagram of my proposed procedure. On the right, there's a diagram or a picture of this barbed suture zoomed in. And this will enable longer duration of an anchor compared to just our temporary anchor for part of this gastrostomy tube placement procedure. Here's an overview of the main components of the study. Like with other minimally invasive procedures, this will be an outpatient procedure with fairly minimal recovery time. So at first we'll have a screening visit to discuss more, to understand if you qualify, answer all questions, and go over a consent form. Then the procedure day will be only 4 hours of time in the hospital, kind of 1 hour to prep, an hour at most to do the procedure, and then 2 hours post-procedural monitoring to make sure the sedation all wears off. I will ask that you don't eat solid food for 24 hours after the procedure to allow the stomach time to heal, just like we ask our patients when we put gastrostomy tubes. We don't necessarily start injecting a bunch of nutrients through the tube because we want to allow the stomach lining time to heal. But the recovery should be much less than a fundoplication. And then I'll have 3 in-person follow-up visits to repeat surveys, do a physical exam, and just ensure that everything is going as planned. If you have hiatal hernia symptoms, before you get too excited, just so you're aware, there are specific criteria that have to be met in order for you to take part in the study. So you'll have to be an adult speaking English with symptoms from a hiatal hernia. The exclusion criteria in the middle column, meaning if you have one of these, you can't be in the study. I'm certainly happy to talk with you because as a physician, I can offer novel procedures that have a reasonable chance of helping. I just couldn't necessarily reimburse you for your time as part of the study. Yes, thanks to the generous support of the American Röntgen Ray Society and a small grant I received, I can reimburse patients a little bit to cover their insurance copays, parking, and cover a little bit of your time if you meet the study criteria. Thank you for your time and consideration in watching this, whether you yourself or a loved one has hiatal hernia symptoms. On the screen is my contact information if you'd like to get in touch with me and learn more. Thank you again.